Have you ever heard of Buerger's disease, also known as Angiography Obliterans or Thromboangiitis Obliterans or Buerger's disease? This condition was first described in 1908 by Dr. Leo Buerger, an American pathologist. Through detailed autopsy studies, Dr. Buerger recognized a unique inflammatory disease affecting the small and medium-sized arteries and veins, especially in the limbs of young male smokers. In today's video, we will take a closer look at what exactly this disease is, symptoms, diagnosis, and treatments. Definition: Buerger's disease is a non-atherosclerotic, segmental, inflammatory, and thrombotic condition affecting the distal arteries and veins of upper and lower extremities. Over time, inflammations lead to vessel occlusion, tissue ischemia, and even gangrene if left untreated. Unlike atherosclerosis, it does not involve lipid deposits. Symptoms: Symptoms of Buerger's disease typically appears in young adults, often under 45 years old, who have a history of heavy smoking. This includes intermittent claudication, pain in the legs or arms during activity that resolves with rest pain in the fingers and toes, which worsens at night, Raynaud's phenomenon, fingers and toes turning white or blue in response to cold or stress, ulcers and gangrene, particularly in the fingers and toes, superficial thrombophlebitis, inflammations of the veins with pain and redness. Unlike other vascular diseases, Buerger's disease involves both the arteries and veins. The venous involvement can manifest as superficial vein inflammation and thrombosis, contributing to pain and swelling. Diagnosis: Diagnosing Buerger's disease is based on clinical criteria, imaging, and exclusion of other causes. Key diagnostic methods: Doppler ultrasound can show reduced blood flow in affected arteries. Angiography reveals segmental arterial occlusion with a corkscrew appearance due to collateral vessel formation. Blood test performed to exclude autoimmune or hypercoagulable conditions. Allen's test evaluate hand circulation before considering procedures like bypass surgeries. Differential diagnosis: When diagnosing Buerger's disease, it is crucial to systematically rule out other possible causes of peripheral arterial disease, especially in younger patients. For example, arterial embolism, particularly of cardiac origin, should be considered in case of sudden onset ischemia or asymmetrical symptoms. To rule out this, a transesophageal echocardiography is recommended early in the workup, especially if the patient has a history of arrhythmia, heart murmurs, or known cardiac diseases. Atherosclerosis is another common differential, especially affecting other older patients or those with classic risk factors like diabetes, hypertension, and hyperlipidemia. It can be excluded through vascular imaging such as duplex ultrasound or angiography, which in Buerger's disease often shows corkscrew collaterals rather than typical atherosclerotic plaques. Additionally, vasculitis and connective tissue disease such as systemic lupus erythematosus or scleroderma should be ruled out through autoimmune panel testing, especially if systemic symptoms are present. These steps are essential to confirm the diagnosis of Buerger's disease and to avoid mismanagement of other serious vascular conditions. Treatment: The cornerstone of Buerger's disease treatments is absolute smoking cessation. Even minimal tobacco exposure can trigger disease progression. Beyond smoking cessation, treatment options include A. Medications. like Iloprost, prostacyclin analog used for severe cases with rest pain or ulcers. Intravenous infusion can help improve blood flow and relieve pain. Dosage: typically 0.5 to 2 nanogram per kilogram per minute IV over 6 hours for 7 to 28 days depending on severity. Analgesics pain management: NSAIDs or opioids for severe pain. Vasodilators and antiplatelet therapy. Calcium channel blockers, example nifedipine for vasospasms. Aspirin 75 to 100 mg daily to prevent thrombosis. Pentoxifylline to improve microcirculation. Anticoagulation: not routinely recommended unless deep vein thrombosis (DVT) is present. Surgical and interventional treatment. Sympathectomy for patients with severe pain refractory to medical therapy. Amputation in cases of irreversible gangrene. Revascularization procedure generally not effective due to segmental occlusions. Unlike atherosclerosis, Buerger's disease affects small vessels where bypass surgery is often not feasible. Prognosis and prevention. The most effective way to prevent disease progression is complete smoking cessation. Patients who quit smoking have a much lower risk of amputation and progression of symptoms. However, those who continue smoking face a high likelihood of severe complications including limb loss. Conclusion: to summarize, Buerger's disease is a progressive inflammatory vascular disease linked to tobacco use. It affects both arteries and veins, causing ischemia, pain ulcers, and potentially gangrene. Diagnosis is based on clinical presentation and imaging, while treatment focuses on smoking cessation, vasodilators like Iloprost, pain management, and in severe cases, surgical interventions. Early diagnosis and lifestyle changes are critical in preventing severe complications. If you found this video helpful, please like, share and subscribe for more medical tutorials. In next video, we will see 10 case-based questions for a quick revision and detailed understanding of Buerger's disease. Stay informed, stay healthy.